All right, so while we wait, I just wanted to see if we could obtain any questions from the audience. I believe we've got the chat function and feature live on Zoom. Are there any questions there as of yet? If not, I can start with one for you, Glenn. What are your biggest challenges when it comes to your spinal cord stimulator trials?
Once you fix, for me right away is making sure you have the right patient. And can you do it under a safe manner to make sure that you're keeping the patient safe and it can be done efficiently without causing any harm to the patient. Once that is done, it's making sure that you're also looking at the hardware, looking at any spinal stenosis or any hardware in the region, and targeting which area of the spine you're wanting to make sure you're covering, whether it be the low back or lower extremities, and ahead of time with the technologist, making sure that you're getting to that area and covering that area while the patient is in the room, in the procedure room. While you're conversing with the patient, asking them questions, where they feel it. In this Boston Scientific Spectra with Infineon lead, you want to get a lot of feedback from the patient in this case.
Glenn, do you always get imaging prior to your spinal cord stimulator trials?
Yes. So I think it is quite important to make sure that, again, help to plan your approach, making sure that there's no anatomical abnormalities, any pathology that in your way, hardware in your way. And again, a lot of times we'll see a lot of post-laminectomy syndrome patients in my practice, so we want to make sure we're not entering an interlaminar space where there's a laminectomy, laminotomy.
Perfect.
I think they're almost set up there.
Yeah, we're just getting ready here.
Look, some of the key points I wanted to bring up is, again, 30 degrees from horizontal, 1.5 vertebral bodies below is where you enter. Making sure that you can use a lot of tools to keep your hands out of the eye of the fluoroscopy, because over a career of fluoro, you want to make sure you're keeping yourself and your staff safe.
Thank you, sir. All right, Glenn, we just need one more minute and we'll be ready to go here. Sorry, I'm multitasking and.
No worries. I know we're going to be highlighting the Abbott company for dorsal column stimulation.
That's great, man. Perfect, thanks. All right, I'm back on.
Forgive me, a dorsal root ganglion trial we're going to be doing today with you, Ramana.
All right, perfect. So welcome, everyone. Sorry about the issues in getting all the equipment in order, but as you can probably tell, switching from one demo to the other takes a little bit of time to get all of our stuff together. So I'm going to talk about DRG stimulation here. Some of the advantages to DRG stimulation, as you saw from my presentation, is that, especially for complex regional pain syndrome, it is superior to our traditional spinal cord stimulation. At that time, that accurate study was comparing DRG to tonic stimulation, of course, with newer waveforms. You might see some improvements in spinal cord stimulation, but I'll just tell you from experience, DRG stimulation really is the answer when it comes to CRPS, one of the most challenging conditions we have in our space. This technology has a long history. Its roots began at Stanford University and then evolved into the company Spinal Modulation, which was acquired by St. Jude, then became Abbott. As I mentioned before, is the only FDA-approved DRG simulation company right now. So we have a cadaver here, and we're just going to pretend that this patient has a history of a total knee arthroplasty on the right side and developed some CRPS-like symptoms, some sympathetically maintained symptoms such as allodynia, redness, a little bit of swelling. The surgeons evaluated for infection. It was negative. Imaging looked quite good from their perspective. and the patient's really suffering and they're 9 months out from their surgery. So the DRG is really where the cell body to the primary sensory afferent neuron exists. And it's a very nice target because it can address that entire dermatome going all the way to your target. So as opposed to spinal cord stimulation or dorsal column stimulation, where when you stimulate trying to get the knee, you're really going to be diffuse and may cause stimulation in places you don't want, and then not get the appropriate pain relief you're looking for at the region you're trying to target. With Drg simulation, you're much more focused, and you see robust changes in not only the patient's perception of pain, but also their sympathetically maintained signs and symptoms. So you can see literally in the recovery room, their color change, their swelling reduce. It's really quite remarkable, the impact that Drg stimulation has on the vascular system and the sympathetic system. So what I do procedurally here, Justin, if you don't mind taking a shot, and if it's possible, Justin, can I have a pedal? A pedal? Do you have a pedal available from the C-arm? Perfect. Thank you. So I'm just going to show you some principles here, assuming we're going for that right L3. And what Justin has nicely done here is that he has lined up the superior end plate of L3. He has the spinous processes basically in the midline. And so what we're going to look for here is, this is our target pedicle right here, right L3, okay? And then we're going to draw a line through that 3-4 interlaminar space. And you can see what I'm doing here is I'm rotating my tunneling tool, this straight tool, and I'm creating a line from the L3 pedicle through the epidural space, as you can see that interlaminar window. So this is going to be the line I'm going to take for my needle. It's really important to draw out on your patients exactly what you're going to do. I would say that's true for all of stimulation. Really start to mark and understand the patient's anatomy, fluoroanatomy or sonoanatomy, so you can make sure the procedure is done correctly. I think this is extremely important when it comes to DRG stimulation because, as you will see, the way the needle is entered, the changes in angulation of just 3 degrees can make a huge impact on how well you get that lead out of the neuroforamen or how well you can make the tension and relief loops. And you might spend 30 minutes just struggling when if you just made a small adjustment in the beginning, you would have saved all that time procedurally and all that fluoro exposure. So I really encourage you to be kind of perfect the first time around. So really draw this out. I don't have a marker with me, but I encourage you to do that in the OR. So what I'm going to do is just find my needle skin entry point. And if I had a patient who was, say, 80 pounds, 80 years old, I might consider starting closer to that interlaminar space, right? Because there's less tissue between the skin and the lamina. However, if that patient were to be, 300 pounds, I might start way out here because I have to traverse all of that tissue. It's really important, just like Glenn talked about, with dorsal column stimulation to stay shallow. For this particular patient, I'm going to basically start right here. And so I'll enter. Of course, I'd use local, but for our friend here, he is well anesthetized. So basically, I'm going to follow that angle to that interlaminar window. And we're going to touch down on the lamina. So I encourage you to feel the bone here. I'm going to angle my way in towards the spinous process. And Justin, if we could collimate, since I like to reduce my radiation exposure. So you can see here what I'm doing is I'm coming off the lamina. And right now, if we extended that line, I'd be coming underneath the foramen. So that's not quite ideal, but I'm touching bone just so I know my depth. And now I'm starting to shift my angle more cephalad, so it's going to start to steer towards that neuroforamen. So what I'm going to feel for here, which you can't really appreciate via Zoom, is that I'm going to fall off that lamina and really start to enter the epidural space. Now, where you enter in the epidural space is extremely important. You need to enter basically right underneath the spinous processes. So if you drew a line between the width of the spinous processes down that spine, that's really the zone you want to enter in. If you are too far ipsilateral, you'll have to go over the dura and then down to the lateral recess and then out the foramen. So it's forcing your sheath and lead to do a snake, basically, and you lose your steerability as you do that. If you're too close to the DRG or too far contralateral, you don't have enough space to work with to create the tension relief loop. So it's really important to enter basically in midline. So as I get closer, I shallow out my needle angle, and I'm hoping to enter, right around midline here. That might be a little bit early here. I'm going to check with a guide wire just to see how easily this is. As you know, cadavers have different feels, so we'll just see how well this. And there we go. It actually went in very easily. So I confirmed I'm in the epidural space with the use of that guide wire. So which way is the camera? All right, so here we go. I don't know if you guys can focus in on me here. Right now I'm blurred, but basically what I want to show you here is this sheath lead system. As you can see here, there's a curve, and in each kit you'll receive one with a large curve and one with a shallow curve, okay? And this is really the delivery mechanism to create the curves and ensure that the lead stays dorsal, right? We're not trying to stimulate the VRG. That's a joke. There is no VRG. We're trying to stay dorsal, right? Because we only want to affect the sensory afferents. So you'll have two different systems. Most of us end up using the large curve. The first dot here lets you know when you've entered into the epidural space, i.e. through the needle. You can see there's a flush port. And the flush port and the curve stay together. So everyone in the room knows what your curve is doing based on the orientation of the flush port. The flush port is actually rarely used to flush anything through. Every now and then I will inject a little saline just to reduce friction, especially in a fibrotic epidural space. And then you have the lead, and I'll just show you the lead itself. The diameter of this lead is 1 millimeter as compared to a dorsal column lead, which is 1.3 millimeters. As you can see, we have a quattrode system, so 4 contacts. We really only need to use 1 or 2 of those electrodes in order to stimulate. What we're trying to do is get electrodes 2 and 3 directly under the pedicle. And then if in case there's any movement, you can always use 1 or 4, but really 2 and 3, we want to be doing most of the work as far as stimulation. And then inside the lead is a stylet, which is really hard to see, but maybe with the white background, you can see it there. This gives the lead a little bit of rigidity, so it's sort of uncooked pasta, and then when I remove this, this becomes cooked pasta. So I like to call this the capellini, or the vermicelli of spinal cord stimulation, and your dorsal column is the spaghetti. Mario's on the call, so I have to give him some Italian props. All right, so we're going to go ahead and start with insertion of the sheath and lead. You can see the needle here. I have the bevel up. The bevel up is the black line here. And it's really important to understand the orientation of all of these pieces. I always want my flush port and my bevel to be oriented together, because if they are not together, you can create shearing of the sheath. But more than that, you really lose your steerability and power to drive the system. So I'll just start out by inserting my sheath, and I'll watch to make sure that the white dot goes across. So now I know I'm in the epidural space. And Justin, if you could collimate circle over the right L3 pedicle, that would be ideal. And then sort of shift, yep, exactly, up and out towards you. And then I'll take a spot shot there. Okay. So what you're seeing here is that the sheath wants to head up the epidural space, which is exactly the pyramidal zone you want your dorsal column leads to go into. However, with DRG, you don't. So it's okay to start here, and then you'll see under live, and we'll do this under pulse fluoro, we'll start to work our way more lateral. And so you notice that it really wanted to really shoot up. So what I've done here is I've retracted a bit and rotated my needle, and you can see here it's starting to work its way over. There's quite a bit of fibrosis I can feel in this cadaver, but that's, what you get. And so what I'm doing is I'm really working my way out towards the pedicle. I'm starting to rotate over, and you can see now I'm starting to duck underneath that pedicle. Justin, if you don't mind collimating a little bit further over that L3 DRG. Perfect. And now, guys, I'm at this point here that I can feel you can't really see, but I can feel the tension right here. And what this is are the neuroforaminal ligaments, okay? This is exactly what you feel when you're doing your transforaminals from the outside in, and you feel that pop or that loss of resistance with your quinky. Now I'm trying to push out, and I'm pushing out with a larger diameter sheath. And it does have some rigidity, but we also know that we don't want it to be too rigid so that it actually dings the nerve, because that nerve is actually being suspended in those ligaments. So it's very common for patients to feel this, to feel a paresthesia. I really recommend talking them through this and not over-anesthetizing, because that could hurt you down the road. So there are a few ways of going about this, and again, this is really usually not as rigid in the real world or with a live patient, but with cadavers, we often see this. And you can see I'm doing sort of a punch technique, and I'm just breaking my way in. I'm wiggling, I'm twisting the sheath. And another, technique here in this situation is to just hold firm pressure, talk about the groceries with your scrub techs, etc., what you're going to buy later that evening, and then try punching again. And again, it's just patience. You don't want to be too overzealous, because what you don't want to do is put so much pressure on that it starts to kink the sheath, okay? So you really want to just maintain the sheath, and you can see it's curving up a little bit, and I'm twisting, and eventually we'll get there. Now, another option here, in case you're like, well, gee, this is taking too long, is I can take the lead out, and I can put in a guide wire. And this will also come in your kit. I don't know if you want to zoom in on this. Perfect, beautiful. So I don't know which camera. There we go. You can see there, it's a nice, firm, rigid guide wire, able to place that through the sheath. And you can see under fluoro what that looks like. Now, if we just stop right here, if you notice right under the pedicle, guys, there's a little dot. That's the tip of the sheath. So I need my guide wire to basically go out to it. You just saw right there. And now it's actually poking through it. But I'm just going to go to the tip of it, screw down the hub here so they're locked together. They're basically married. And then just push. Keep on doing the same thing. And now I'm hoping the increased rigidity will help. And we're just trying to work our way out. And then another technique is to get a little saline here. And just like I mentioned before, reduce the friction. Make sure that hub is really tight, because otherwise you're going to shoot saline back at you in the face, and that's not pretty. Those are not good style points. So we'll just inject a little bit. And I can tell just by the pressure here that it is pretty tough in there. And so you can see some of the fluid backing out because it's really tight, and that's okay. It's just what we have to deal with. And then we'll try once again. And we're punching. And you won't need to be this aggressive in the real world, but it's just because it's a calcified neuroforamen. And then eventually we'll just push through. And as you can see, we've made some progress. There we go, I just popped the guide wire through. And now I'm going to just try to follow that path the guide wire just took. So it's looking pretty good. Let's see if I can actually push the lead out right where the guide wire went, because I'm fairly close to being on the brink of kinking my sheath, I can tell just by feel. Okay, and here comes the lead going through that sheath. You can see it wraps all the way through. See if I can push it out a little bit further. There we go. All right, so this is the ideal location, contacts 2 and 3, right underneath the DRG, or right underneath the pedicle, excuse me. Justin, let's check a lateral now. Let's make sure that this really has remained dorsal. So this is a good time for you to just take a break, take a big, deep breath, really ensure that your lead is right where you want. Also make sure your mask doesn't fall off your face. With all the apparatus on my head, it's pulling down everything. So I'm going to grab some new gloves here, Tyler, if you don't mind. Thank you, sir. All right, beautiful. So we got a great view of that foramen. And what we're looking for here are where the contacts are located. Is there a screen, one of these screens I can stand next to point out some things? Yeah, viewpoint restricted. Okay, perfect. I'm gonna walk around here and I'll just point out the image here, which is really important. So you can see the 4 contacts here. What you wanna make sure is that those contacts do not cross the posterior border of the vertebral body. Here you can see the foramen. The DRG is really sitting high and tight in that foramen, so this is perfect. This is golden. This is exactly what we wanna see. Those electrodes are also radiolucent in the middle, so sometimes you'll see a Cheerio, and that's a good sign as well, because that means that electrode is shooting right out at you. So this looks perfect from a lateral view. I'm really happy. So Justin will come back around to an AP. And now, really, the procedure begins, because you might be thinking, well, gee, I just got my lead out over the DRG, like I'm super happy, I'm done. But actually, in my opinion, this is where it begins, because now the most important point is ensuring you have good tension relief loops. This is what's going to be your anchoring system with DRG. So first thing I do is I take out the stylet. I'm going to create that lead to cooked pasta. Now it's just going to sit in that space, okay? And I'm going to pull back my sheath. And you can see the dot of the sheath coming back. I don't know how well you can see it. Whoops. All right, and I said whoops because I just pulled back a little bit. There we go. And you can see I'm feeding the lead, and it's heading cephalad here. Perfect. And I'm pulling back my sheath. You can see I've made that cephalad loop, and now what I'm going to do is I'm going to turn my whole apparatus to the right. And what I'm going to try to do here is create a caudal loop. And I'm going to do that just by pushing some lead in. So it wants to do the funky loop here. And that's okay, because there's just some stuff we have to contend with. So there is something blocking there. I'm going to pull the lead in a bit, and I'm going to drive it up a little bit further. I'm going to pull that lead back in because I'm not getting quite the caudal loop I want. I'm going to take this sheath up more towards the midline here, and now advance my lead a little bit and pull the sheath down. So that looks fine. And I'm going to actually here in this position shift everything over. You can see here my needle bevel is pointed towards the right, but my sheath is still curved left. And a big part of that, again, is fibrosis. In a live patient, you're going to have a lot more epidural space, more fat. So there's going to be more room to basically maneuver. But right now, because everything is compressed, these cadavers have been sitting for a long time, things don't want to turn very easily. So we'll just try to work with what we have. And there we go. We got a little loop there. There we go. And we're seeing a little bit of that caudal loop here. And now let's see if I can just finish it off with a little. And there's a lot of give and take here when it comes to this stuff. Let's see, that cephalad really crossed over, so I don't love that. We used to really be opposed to crossovers, and a big part of that was because when the first iteration of Drg Simulation had a ball tip, and so obviously if you tried to pull that out, you'd meet a lot of resistance. These leads do not have a ball tip, so typically when they come out, they'll come out in the path that they're actually lying down in. But we try to not have too many crossovers because that creates a lot of fibrosis as it heals down. But if you end up with a crossover, as you probably will see from certain people's Instagram or LinkedIn images, it's probably just fine. So what we've done here is we've created an S, and if we took a lateral, which Justin can do if you don't mind, we'll take a look, because even though it looked like there was a little bit of overlap or crossover, when you look at lateral, there's actually usually a little bit of distance between that contact point. So remember, everything is three-dimensional. Even though under 2D it looks like they're overlying each other or crisscrossing, under lateral you may see that they certainly are not. And this is actually great, because you can see where the leads now actually have some depth, and that loop that I made the last loop I made is actually a little bit more posterior than the initial loop. So there's actually quite a bit of distance, and we can come back to a AP here. All right, so that's basically the DRG trial with the lead placed there. Glenn, did you want me to go into implantation with the IPG at this point?
You have 5 minutes.
Okay. Sure. So I'm going to demonstrate, we can do it with this DRG lead here itself, how it goes to place an IPG. So I'm just going to feed the lead and ensure that that remains in place. So we'll talk about the IPG implantation with the DRG, but really the same principles can apply to spinal cord stim here. Tyler, is it possible to bring over a scalpel and... Perfect. So I would say that the most important thing you can do is really, talk with your patients about IPG placement. One of the tips and tricks is to consider having them place a dental floss box over an area that they want to have the IPG. You'll probably read about and hear about very, different places, whether it's the upper buttock or over the flank. These are all potential places. In some cases, particularly with a wheelchair-bound patient, like in situations you have spinal cord injury, some patients should have it in the abdomen just because you don't want that IPG to create an ulcer. Thank you, sir. So a lot of considerations to take into account when you think about your IPG placement. For this particular patient, we'll just place it in the upper buttock on the left side. And then, Lindsay, we've got a little template here. So we'll just use this IPG, but really, what I'm going to show you is applicable to really any of the systems here. Tyler, do we have a marker by any chance? Great. So as I mentioned, I think it's really important to mark out everything when you're placing your leads, but certainly when it comes to the IPG, I tend to follow Longer's lines. So that was a surgeon way back when who figured out that when you oppose skin, you can start to see these horizontal lines, and you can actually look at it. You can Google it yourself, Longer, Langer''S. And if you follow those lines, you'll tend to see a better cosmetic appearance if you follow them for incisions. So I'll just move out a little bit lateral here. And I'm just looking at those Longer's lines. I'm following them perfectly. And for this particular system, the Abbott Proclaim, I follow the interface between basically the plastic silicone and the metal, which is about 4 centimeters, and I draw a line, so like so. And of course, I'd use local anesthesia. I start with the 27 gauge and then follow with the 22 as soon as the skin and sub-Q is well anesthetized, hold some pressure, retraction, and then incise firmly. Okay, and then you'll get the adipose here. You can do a couple things here. I usually use a little electrocautery, make sure I have hemostasis. With these non-rechargeable systems, you can get down to a depth of 2 to 4 centimeters. You don't have to be superficial because you're not going to be recharging them. So once I find a nice plane below scarpas, I just try to feel a nice plane that I'll develop out. Again, I would usually use electrocautery. We don't have this here, but that's okay. I'll use my blade. And then finger dissect. You can also use a METS to do the same. Okay, perfect. And you'll often have a template, not the actual IPG itself, and you'll just want to make sure that template fits in nicely. And so I usually have my incision, there are different ways of doing this. I usually have my incision sort of overlapping that metal silicone interface. Some people like to make the incision and push the IPG all the way down so that the incision's over it. It's really your choice, but the most important thing is that you don't have too much tension with that wound, right? Because you don't want this to dehiss, you don't want it to be susceptible to infection. So you really want to do a good job here because infection is one of those more challenging things to control. You can do a lot to control migration, you can do a lot to control lead fracture, but infection is one of those bugaboos you really have to be meticulous about to make sure you don't have them, even though, if you're doing enough of these, you're going to see an infection in your lifetime. So for this particular system, I'm just using different things here. So we have a tunneling tool, but given the distance is relatively short, I can just use a TUI. So I will just use this TUI from this lead position and tunnel to my IPG here and curve it out. Perfect. Make sure you don't poke yourself, really make sure of that, and take out the stylet. And then thread your lead through. Again, you'll have a tunneling tool, and I guess I should have reversied because I'm trying to be MacGyver here and not have to use that tunneling tool. But because that hub is in the way, I can't do that, so I'm going to come around the other side and make sure I don't damage my lead. And so I'm putting pressure on the lead right now. There we go. And now we'll get that through the bevel. And once you get all that through, perfect, pull that out, comes through, and then connect your IPG. I think for the sake of time, I will just show you that we just place it in. These are not unscrewed, but you'll put it into the IPG ports. You'll screw down, you'll check impedances with the reps, and they say everything looks good. You'll put it in, they'll check impedances again, and if all that looks good, you're set to go. You can irrigate and close.